member comment at the end. But thank you all for joining us, and I will hand it over to you, Rich and Udara. I know I'm recording. Are you also recording? Wonderful.
Wonderful. So I want to really maximize the amount of time that this group can reflect and comment. Chelsea, Udara, and I will be taking copious notes. Ideally, we'll stop about 10 minutes before we have to transition back to the group and try to synthesize some of the key points. I will presume that you have your worksheet handy, or at least have the on your screen, but I think the way we'd like to do this would be to go domain by domain by domain. And remember, we want to be asking each of you to reflect on what's missing, what is good to go as it stands, what needs refinement, what should be retired, and then thinking along that trajectory of, I'm still using the term air quotes whenever I think about interoperability. I still see patients, and I'm still waiting for that unicorn to show up of true interoperability. So we're thinking about really a spectrum, if you will, of early interoperability. And as we've described, that's basically sort of current state and who's exchanging what. Intermediate interoperability really gets at, and it would be great in order to facilitate care communication and care coordination. We don't have it today, but we need to push in that direction. And then this sort of advanced interoperability, which I hope with the efforts that are afoot between the ONC, CMS, and the community of vendors, that we're moving in that direction, where we're able to make this a dynamic process that includes pretty broad usability, with the patient having overarching control. So that's sort of the framing for this. I'd like to be able to open this up. I really want to encourage input from everybody. So first domain, collecting and sharing data.
I guess it's Alexis. I guess one thing that I have a few things jotted down, but I think one of the most important things in this area that I thought about as I read through the list was that I thought was missing was allowing intake from the patient as well in updating the EHR, or at least, being able to have the input, and then it gets, looked at by someone else as to whether or not it should be used in the EHR. In the same fashion as, before you log into an appointment, you're given if you're doing telehealth, given a med list. And you can talk about what could come off or what needs to be added. And same thing with problem list. You're asked to update your problem list. It doesn't get updated in real time, but it does go in, and then somebody looks at it and approves to make a choice or not. So at the very least, some of that input, as also allowing outside records, if they haven't in our flawed system so far of interoperability been able to come over from one health facility to another, the patient should be able to provide their provider and that health system the information that can then be put into the EHR. Even if it's a physical document, should be able to be uploaded.
Stick with that last one. I'm sort of leaning into it because I happen to be a pediatrician, but give some more examples that would be relevant across the age spectrum, specifically that third point.
Sure. So let's talk about, like, say, getting labs done. And you have a laundry list of labs, and maybe one provider at one facility is ordering it, but you may happen to get your blood work done at another facility. It's very difficult to sometimes pull over the information from one hospital system to another. So if the patient is then asked to provide it, if that person is using, say, third-party apps on their phone, and they can log into the portal, they can show their doctor right there, oh, here it is from their system, from their EHR. But If you're not able to do that, or even don't want to have to do that, you should be able to, if you're able to obtain that record to begin with, right? But let's assume that the patient has a printout, or at least access to the portal to print out their medical records, be able to then provide that to the other provider, and it should be taken for what it is and be able to be uploaded into the system. Does that make sense?
Yeah, that's great. And then, you know, my own bias as a pediatrician, I'm thinking about early intervention, special education, and other types of sources as well. All right, so that's a really great start, Alexis. Thank you. I'd like others to jump in now.
I think one thing, this Joe Kunish, and I work in the Texas Medical Center, you know, and I think we're the third largest public health system, Harris Health, and something that really just was really highlighted when this current surge, which we are just being slammed. I am talking 100 people in the ER, 100. You know, you're talking a bed capacity of 20. It's insane. That's how insane. But we lose track of patients. And if you're familiar with a medical center, you literally can walk out one door 30 yards and be in a whole different hospital system. So we may have already started care on a patient. They get frustrated because there's 80 patients in front of them, and they walk out of our system and over to our neighbor, Memorial Hermann, and we have no idea they went there. And we're actually seeing safety events that we're reviewing, and then we find out later they went over to Memorial Hermann, and there was a different outcome. And so the timeliness of this data in these emergency situations, really, I just can't stress it enough. That, you know, we can't wait for it to get uploaded into the HIE and then be available to the EHR. It's almost like it has to be a live stream feed. So if a patient leaves after we drew labs, already did a COVID test, we can at least see, did they go to another health system within the proximity? Or did they go home? Or are they sitting out in their car? I mean, you know, if they don't show up in another health system and it's a critical result, we expend a lot of resources just trying to track this patient. Now, there's always been issues around tracking certain populations with, you know, some, what we would consider, you know, critical results like a positive lab test. But in general, we have a pretty good sound process, but we found that that process falls completely apart in a situation like this. And it's really, you know, like I said, it's really knowing if that patient is in another healthcare system. So and then for that healthcare system to see, oh, they just came from Harris Health 3 hours ago, and Harris Health already did all these tests, and here's the results. Otherwise, you know, that system is treating them like a brand new walk-in, unless the patient tells them. But even if the patient says, yeah, I was at Harris Health and I had this test, and this test, unless they pick up the phone and call, and in this situation, they'll be lucky if they get somebody to answer the phone. They're not going to know, so they're just going to order the test again.
So Joe, thank you. Francine, you've raised an important question that I'd like to see. Are you able to speak, Francine? Great. And so Joe, stand by, because I would like to have you address what Christine's asking.
Yeah, so I would have to foot stomp if there was, this is, oh wait, I don't think there we go. I'm an emergency medicine physician, and I can't even tell you how many times I've had a patient come and I work in the VA, so how many times I've had a patient come to the VA who'd already been seen in the community, who had $1 million workup, and either didn't wait for the results or wasn't satisfied with the results of the evaluation. And I actually sent a patient to a hospital for the same study that he had just received at that hospital. If there was some way that information could have been pushed into my, granted, my electronic health record currently is not capable of receiving that information. But the ideal world would be, as soon as I went into that patient's record, it pops up and says, oh, this patient just had a visit at a partner hospital. And it may even be that, they maintain a list of places where the patient had previously been seen, and then that list communicates between the facilities, so that common, transitions, we send patients out all the time to Penn. So a patient that had been seen in Philly and in the VA in Penn, it would automatically push that information into the other medical record instead of waiting for that pull.
Yeah. So does that, I think that complements, Joe, what you were saying. And I'm hearing everybody say timeliness, because, all of the systems that I'm familiar with in the Boston area have what we call ADT feeds, but there's usually a huge lag. So timeliness of information sharing is the trigger. So I think that's what you're mentioning, and Francine, I think your notion of both redundance, duplication, and in the opioid space, this has been one of the things that actually has gained traction around, okay, who's received a controlled substance prescription from anybody else in the Commonwealth of Massachusetts at a period of time. And so the technology is available.
And Ann Pullage from Nebraska, and I work for an HIE, so, but physician background. There are, as you were saying, Richard, ADT feeds, but also you can buy applications for your EMR that will tell you real time, even on your bedboard, if a patient has been in another locale. Some of the folks who have these things are like CMT, maybe you've heard of Collective Medical. I think, but stepping back for a minute, in the state of Nebraska, we are the mandated HIE, and so we have both the PDMP, which is medications, and then we have the clinical viewer, which is the longitudinal health record. So in many of the large healthcare systems are integrated. We're integrated with them. So you press a button, basically, if you're at the University of Nebraska, delivering healthcare, and you can see the display of where the patient's been, what their medications have been. So I think it's probably irregular throughout the country about what's possible, but there's already quite a few adjuncts that go along with the EMR that certainly is very helpful to clinicians. I know, Carol, in the VA, I've been in the VA too quite a long time. You can get on the JLV and look at the eHealth Exchange. It's not super great, but it is, at least will tell you where the patient's been most times. A lot of times you get rerouted in that and have to go to Vista. So I think this is definitely starting, and trying to figure out, though, how to optimize it for clinicians is probably where a lot of the rub is, unfortunately.
And can I make a comment on that? Because we actually did, when I came from Memorial Hermann, which is the largest healthcare system in the Houston metro area, and we actually did talk to Collective Medical. We didn't see value, of course, in our own system, because it's like we already have access. Trying to coordinate to get other health systems to, contractually say, yes, we'll use this and share this information, and what that information is. We try to get other health systems, Methodist, which is another large health system here, involved. that was a Herculean effort that went nowhere, because, you know, bottom line, you have to sell it to the executive suite, and there were, what is the value here? We have our patient population, that we want to retain. You know, now Harris Health, we're a public health system. we're not worried about market share. Our market share is built in. But these other ones do worry about their market share and patient leakage and all that other. So yes, you're right. The technology there, nobody's forcing us to use it. And there has to be a good reason to adopt it. And plus it costs money. You know, Collective Medical said they'd give it to us for a year for free if we signed up, and we still couldn't get people to bite. So just wanted to kind of add that on to that discussion.
Yeah, I
Thank
totally
you.
agree, Joe. I think though the thing
Actually,
is
Anne, unless it's a
interoperability.
unless if it's of a different topic in this domain, I really want to move us forward. If it's the same, I'm going to ask you to put it in the chat. Walter, I have so much respect for what you've brought to this conversation. I can't leave this domain without giving you the opportunity to talk about the SDOH piece of data. So, and I won't even apologize for putting you on the spot. So out of this is deference and tremendous respect for what you've brought. So riff a little bit on SDOH and data collection and sharing.
Well, I really, you know, I've been trying, first of all, thank you so much. And I'm not feeling put on the spot at all. This is such a good conversation. I've been really trying to nitpick, but I really feel like the group has done so much good work leading up to these bullet points here. It's kind of tough to find something that I would add or edit. Honestly, I think it's a great list. In fact, I think what we've come up with so far for all the domains, it's really, really solid. So I'm sorry I can't be very.
Oh, no. That comment is an affirmation, and I also want to celebrate, you know, what the committee has done, and in particular this NQF staff. So that's really, really important. I'm going to move us now into optimizing usability for clinicians and patients, but I am going to exercise the chair's prerogative and just call this out, and then I will do this later on, is I don't really know what a care plan is. It sounds and feels and looks like a unicorn to me. However, in my work with patients and families, it literally is the coin of the realm. It's here's what the next 60 days of your child with technology dependent needs to look like, or Uncle Walter, who is a frail elderly stuff. So I do want to flag that we could talk about care plans being part of the data that's collected and shared, but we've got to, just like with SDOH, we've got to come to some sort of agreement about what are the elements of the SDOH data, what are the elements and the structure of that care plan. So I don't, we could spend the afternoon on that, but I needed just to put that there for the minutes. So let's move into the next domain, please. Optimizing usability for both the patients and families as well as the clinicians. So comments, please.
Rich, Katie Balistraci. I am a health services researcher, develop quality measures for CMS, and have developed ECQMs. We talked about it in this group for a while, and so I'm throwing out a question, I suppose, about whether data standardization has a place in these recommendations or will be represented elsewhere. Race is not collected the same way across systems, right? Both in the number of categories that are collected, the way it's collected. As an example, I imagine, and I know from some experience, there is some medical data. Likewise, a unit of a blood transfusion is not actually the same volume necessarily from hospital to hospital. So I don't know if that point has a place in these recommendations or elsewhere will show up in our final product. But I just need to restate the importance of that.
That's actually why I wanted to prompt it. But the good news is that Chelsea and the NQF team have this topic teed up when we dive into the so-called gravity project. So Chelsea, feel free to add to that. But Katie, I want to tell you, I come to work every day thinking about what you just said. So Chelsea, please jump in.
Yeah, so during our next meeting in February, we will be focusing on SDOH data collection and both the collection of the data, but spending a little bit more time on the uses and what it means for care coordination and quality measurement as well. The Gravity Project is a fire accelerator project.
Yeah, it's an accelerator group. I'm familiar.
Yeah.
Thank you. Yeah. Okay,
so,
terrific. Again, I just didn't know if it had a place in this list of recommendations or whether we had another way we wanted to approach that important topic.
Yeah, it's duly noted. Anything around SDOH and health-related social needs and performance measures as well. So Katie, totally assure you of that. And it's so important that it's going to be a significant for the next webinar. Okay. So usability, patients, families, caregivers, clinicians.
Rich, it's Alexis. I would just say that what I thought was interesting about this section where it's labeled as usability for clinicians and patients, there's literally not one bullet point that has something directly related for patients. So all of them might be directly related, but there's nothing that directly responds to reducing any burdens for patients or increasing the usability.
So Alexis, thank you. That's, I think, your second gold star in the last 20 minutes. But tell us some more. And notice when I use the word caregiver, because I don't want this to be simply, well, Alexis is checking on her teenage daughter stuff. So patients, families, caregivers. What's missing, Alexis? And then anybody else that wants to weigh in as well. This is a big gap.
Well, I mean, there's a lot missing, but I was just saying that, there's really nothing there that directly relates to reducing the burden for any patient or caregiver, no matter what age a caregiver, the patient of the caregiver is caring.
But say more. How could we reduce? What is the current burden, and what could technology do to reduce it?
So the current burden, in generally speaking, is that because of the lack of interoperability, is having to be the go-between and the middle person, right? And having to be the communicator between providers and between healthcare systems. That's the big obvious one. I'm trying to think about some other directly related burdens. I mean, just reducing the time, and even going back to what I was saying about collecting data from a patient, there's really very little voice that a patient or a caregiver has, within their EHR and controlling, mistakes or getting mistakes corrected, or when information is not just one-sided during a visit, and being able to have the perspective of patient and or caregiver. And then lastly, I guess I would say that for caregivers, especially when it comes to someone whose, say, child they're caring for is now considered an adult, or even some EHR systems and some portals don't allow parents to have certain access after age 14. And then those who are caring for elderly parents, or someone with a mental illness, et cetera, not having access to the records that they need to care for this person at the right time. So there's just a lot of burden reducing, or things that would reduce the time that it takes for people to help be a caregiver.
That is profoundly important, and it's deeply sad, but it's true. So who else would like to add to that, and that notion of burden, right? Why is care coordination important? Better outcomes, including reducing unnecessary burden. But I want to hear some more folks.
Hi, this is Colleen. I'm with the College of American Pathologists. So we have, I guess, a bit of a different problem than a lot of, I think, the clinicians on this call. I mean, first of all, the electronic records that we use are not EHRs, so laboratory information systems, and that alone poses a tremendous challenge trying to make sure that the LIS connects to the EHR at all. But specifically when it comes to patients, you know, there has been a move both legally and sort of societally to have patients access their lab report immediately as soon as it's available, which is, I think, a net benefit, but I know does raise a lot of concerns about the burden that that places on everyone. That, you know, it's great if patients can access their report. That does mean that the report has to be understandable by patients. It should not be written in a way that causes patients distress. And there's the risk that that would put some burden on patients to say to their, you know, their clinician, oh, did you see this in my report? Which we certainly don't want to encourage. So I think when we're talking about usability, we have to make sure that the burden is not like accidentally being pushed onto patients in an effort to make it more accessible and make them have access to everything that they want to have access to. You know, it shouldn't be on patients to interpret a pathology report or say, oh, I looked up all of these things and I think that, you know, I'm not being treated appropriately. If they want to be that engaged in their care, that's fantastic, and that information should be available. But I think the concern is the pendulum essentially swinging too far in the other direction.
And so that sounds like it's challenging, but not more in the functionality space than necessarily the technical space. But I can appreciate that, Colleen, because it gets at a couple of issues that were raised before, is the timing of the results. But you've raised another aspect of results, which is the contextualization and the framing, so that you're not simply checking a box and potentially scaring a layperson, just so that you can meet a deliverable.
Yeah, when we're talking about optimizing usability, I think that's a huge part of it. You know, one of the bullet points on here, I think, is visualizations of patient data for clinicians. I mean, if the reports are going to be available to patients immediately, it would also be visualizations of patient data for patients. Like, how do we optimize that to make it accessible for patients without putting burden on patients?
I also was mindful that you made the observation that your database, because you're a member of the team as the pathologist, is not necessarily directly connected to the EHR. So there's another opportunity there that isn't just that's likely an intra-institutional, not just an inter-institutional issue. Alexis.
Yeah, I mean, I hear what you're saying, but I think that, you know, with sensitive information, there certainly could be a time delay. We're not saying that, you know, when patients and/or caregivers need access, that they need instant access. We don't expect someone goes and gets, you know, an X-ray or an MRI, and there's sensitive information in there about cancer or something your doctor hasn't had a chance to discuss with you, that you should see it first. It's not about immediate. It's about, you know, increasing access, you know, overall. So it's okay if there's a short time delay, as long as the accessibility is there. But then on the other hand, some of what was said about, you know, patients shouldn't have to interpret the results, or we don't want people to flag something and ask another provider, did you see this in my record? I mean, first of all, as far as interpreting results, that's patients aren't asking for them so that they can interpret them. And I think that these problems do exist for some people, not for everybody, but that's like another conundrum of the healthcare system. It's another system issue beyond the interoperability. It's how people are sharing notes, what they're writing, being careful about the wording, careful about the timing. But that doesn't mean that we should back off on patients having access to their information and owning their information. And then lastly, the second piece that I think I sidetracked myself now about what I was saying, shoot, it'll come back to me. I'll raise my hand again when it comes back to me. It was another point on what was just said about interpreting data, but I can't think of it.
Well, you raise your hand or jump in. I want to move us now to the next domain, which is the documentation performance of care communication and care coordination of the activities themselves. So moving into the third domain, open it up again.
I think Alexis remembered.
Bring it.
Just so I don't sidetrack us before we move into the next category, it was about flagging something for another provider. There was a comment made like, we don't want to encourage patients to find something in their record and then flag it and call it out. But we absolutely do want to encourage that. Things are missed. And if the patient goes to an appointment, that's what shared decision-making is about. If it doesn't come up and somebody has missed it, absolutely, it's another set of eyes to point out a safety issue.
Yeah, in fact, I think that really just reinforces your opening comment on the first domain. Is the EHR is about you, and you should be its steward and curator, and the ability to say, no, I never said that I did such and such, et cetera. And I think that really gets at the point of what I think of when I think of patient-centeredness. So it is about timing, it is about the framing and the expectations. So thank you for reinforcing that. Documentation, care communication, and care coordination. I'll say something provocative just to get your juices flowing. One of the best nurses here at Boston Children's Hospital in our complex epilepsy program uses Microsoft Outlook as her registry because she doesn't have a way of tracking the 120 kids or so that she tracks, who needs what by when. So she uses an Outlook calendar, and I say, God bless you, and we'll work on it. But you shouldn't have to do that to manage populations. So I want people to be thinking about now the actual functionality of communication and care coordination.
I don't want to feel like I'm the only one talking, but since no one's talking, I'll jump in again. The thing that I had noted down in this section was in reference to the identifying care teams. And I think this is something that ONC and High Tech has been working on as well, but and in the US CDI and collecting who the caregiver is on the list, but really allowing for other members besides clinicians to be listed on that care team. So even talking about say a social worker from a school system, or PT, that may, or a massage therapist, somebody who's not within the hospital. And then taking it even one step further, caregiver, as part of the care team. So anybody who's actively involved and has information about the patient should be listed as part of the care team.
And this may be a tall order, and I mentioned this in early conversations, but identifying potentially a lead in the care team, or someone who is the main point of contact for the patient. And bonus points for something we try to do with our care teams. I agree, it's a care plans. I agree it's a unicorn, but when you have a goal, seeing who is responsible for that specific goal, and being able to hand over the baton. It's a really tough thing. It's a great idea. So I don't know how, but as an idea, it's a good one, I think.
Walter, thank you for that. And so there is a international concept that actually embodies what you just said, and it's called the integrator. And this was partially some work that we were doing with the WHO, where they actually have a statement on person-centered integrated care. Notice they didn't say patient-centered. They actually went farther upstream. So before you become a patient, you are a person. And that notion of the integrator it's easy if it's a child, right? But that if you're complex, then well, wait a minute, maybe it's my spouse, maybe it's my cousin Harry, et cetera. So I want to call that out. It harmonizes beautifully, Alexis, with what you were just saying. The family should define the care team as opposed to the medical, the hospital defining what they think the care team is, and then somehow you have to fill in the gaps.
Or at least defining it together. right? I mean, you
Well,
don't
that's-
want a patient
it's a
or
joint
family
effort.
member to cross someone off the list who's actively involved because they're a clinician, but.
Absolutely, absolutely. And I think it's part of the reason we have a global conundrum of comorbid poor outcomes with mental health conditions, because for so long we've had a complete wall between medical and mental health systems, and trying to defragment is key. Others that want to jump in on this idea of communication, care coordination, defining care teams.
I just wanted to bring up, and this is not within the EMR, although great conversation about how it should be. You know, Aunt Bertha, Activate Now, Unitas, several organizations outside of the EMR and really outside of healthcare have really done a lot of work in connecting exactly what you're talking about, social determinants of health, mental health, all things that are extraneous to the healthcare system in a bi-directional way. But I think still in its infancy, and many would maybe question if that's the best approach, or if the EMR should be, or EHR should be kind of able to do those kind of connections for care transitions, et cetera.
Interesting. Interesting.
I think it's a case of private sector finding there's a need and then building it out.
We're a Unitas user, Anne. It was NowPow before, and they just got bought out. And it's pretty well integrated, and it does show promise. It's not perfect, but it's a good start.
So what needs to happen to move in that direction, Anne and/or Walter?
Well, what we're seeing is that healthcare is being kind of asked to solve a lot of community-based issues. And so one of the issues is that community-based organizations that are represented in Unitas and NowPow, if there's bi-directional feedback, loop closure, et cetera, but sometimes that information is outdated, or someone is listed, or an organization is listed, but now there's a wait list. Now they don't take this payer or that payer. And so like real-time updates of that information is really tough to maintain. So that's a challenge that we're seeing.
So that theme, I'm gonna suss out what we're talking about here. This is not necessarily a technical barrier, is it? It's defining teams, and I actually like the spirit of this, because that third domain gets at the idea of, just because the EHR can do this, if the system wasn't designed to accept that role, responsibility, and activity, then you've got somebody, you've got a useless resource. All right, I'm going to move us on. Oh, go ahead.
I was just going to say, I think as interoperability really takes hold, and health systems and others have to really decide to what extent they're going to be able to share information. And so, to Walter's point, Unitas is very helpful, but has limitations. And so, do we want private entities trying to line up around the healthcare sphere? We know that 70% of health is outside of health systems, and we also know that it's patient-centric to follow the patient wherever they go. So I think it's promising, but will this be its final form? I don't think anybody thinks that. It's just kind of entry into the market at this point.
I'm going to make a transition statement to get us into the final domain, and it really is this: if you collect this data in the medical place, because say that's what Medicaid is expecting you to do, but then this other data comes in, who's going to track that? How do you integrate it around that role, and then try to avoid what Alexis has been so eloquent? It's one thing to give patients, families, caregivers the resources that they need and the access that they need, but if the system isn't organized around them, it winds up becoming more of a burden if the system A doesn't communicate with system B. So I'm making that statement as we start to bring in a more robust set of data for SDOH and health-related social needs. But it has to be configured in a way that the team is well designed and people understand their roles. And that brings us now finally into this fourth domain, assessing the quality and performance of care coordination and care coordination activities. So I sort of felt that 3 was kind of the functionality, 4 is going to get us at some of the types of measurement possibilities. Did I see a hand and I missed it? No.
Yeah, Richard, I just had a comment about the previous section, but we've moved on.
Oh, no. Brett, please.
So I think the final bullet point in that third section is important. Healthcare providers are too busy to keep up with the best evidence for treating certain conditions, or at least all conditions. I think we've got some of this built into our EMR, building in evidence-based care pathways that, suggest appropriate treatment plans is a gift to both providers and to patients. It shouldn't be built in such a way that they override clinician judgment, but I do think that's a valuable part of what we're talking about.
Yeah, I love that. In fact, I'd like you to stay on the podium if you can. That's what, whenever I talk about evidence-based versus evidence-informed, and especially for patients with multi-morbid complexity. So what could we do, Brent, so that it doesn't feel cookbookish, but it really feels to the patient and family that they're taking into account the strengths and the needs of that particular individual?
My thinking would be a lot of that is in the design of those care pathways in terms of the content that you build in there. And perhaps a disclaimer at the beginning, this is not intended to override clinician judgment, but based on a thorough survey of published literature related to this condition, the following interventions are shown to be particularly effective. And you might consider them in formulating your treatment plan with patient and family.
I really like that a lot. Unlike some of my docs that have actually had people fire patients because they had the audacity to go to the internet, I actually encourage patients to go to the internet, because as soon as I say don't do that, they're gonna do it. And basically what it means is families can come in with any question. Gee, can I cure autism with snake oil? Well, thanks for bringing that to my attention. Let's talk about that, et cetera. So I think, and I purposely wanted to let you know, as a clinician, there aren't nearly as many evidence-based, in concrete pathways, but I love the fact when families can weigh in. So Brent, thank you for those comments. Quality measures and performance assessment around communication and coordination.
This is, really close to me, because this is really my main job. The quality measure. How do we capture good, meaningful quality and provide that information then back to clinical people and everybody involved in the care to make things better for the patient. And this becomes very difficult because a lot of the information still remains siloed, and when we get into care coordination, that even is even more pronounced when you send people out to services or support things like food banks. And it's not necessarily considered a healthcare organization. Houston Food Bank is one of the largest in the nation. And so we refer a tremendous number of people over there under our food prescription program. But we've really had to come up with a fairly resource intense way. Do you know, are they going and utilizing those resources? There's no electronic way. It's just not. And you really almost have to have dedicated people doing this. I also very familiar with the program. I know Brent is too over at Memorial Hermann. Under the leadership there, they do a lot of work in this space in the community health. And I know, from my past experience with working with that team is again, it's very disconnected information because these community resources might not be looked at. They don't have EHRs. They might have other type of electronic, tracking, systems, meant more for logistic type thing. So how do you get that information back to know the patient actually went there and utilized those resources?
Joe, thank you for that. It's so profoundly scalable. In my approach to measuring care coordination, I call that closing the loop. Traditionally, you can hold somebody responsible because you screen them for, say, housing insecurity, food insecurity, depression, whatever you screen them for, and then you, quote, make a referral. And because that's something that you can measure, one could argue that, okay, that's a good measure, but we know actually it isn't. And so I really appreciate, Joe, you're calling this out. It's one thing to say the pulmonologist is going to refer to cardiology in a closed system, and even then, close the loop doesn't happen all the time. But you're really moving us into the space around those health-related social needs. And how do we measure loop closures for those referrals? It applies across the age spectrum. Others would like to talk about any other aspects of measurement. And just to do a time check, I'm going to go for about another 6 minutes, then we're going to stop. We'll do a quick distillation, make sure that we haven't forgotten anything, and then we'll get ready to transition back to the big group. But any other comments about measuring performance of communication and care coordination?
Rich, I think some of it goes back to what Walter was saying about having, like a leader or a champion that's kind of, overseeing the care plans. I know a lot of this section, I don't have the bullet points in front of me, but I had made notes about care planning. There was a lot of discussion, I think, in the bullets about measuring the adherence, which is a word I actually really can't stand the word adherence. But to that regard, again, where is the voice? Is the patient in alignment with what this care plan is? And if not, are we finding out why they're not following through with something that was recommended, rather than just measuring that it wasn't adhered to? And I think that, again, it goes back to, somebody being responsible to follow up. So not just having, goals and outcomes, but who's actually accountable at the end of the day for them.
Others? Well, you're all thinking, Alexis, I'm an advisor to Massachusetts Medicaid, and we are now in our 5th year of our 1115 waiver for accountable care. And there was a very purposeful effort to engage these community resources. And I can't tell you how many times I would sit in meetings and look at the performance across the 12.5 ACOs in Massachusetts, and the ones that are making the kinds of referrals that Joe was just talking about, sort of community resources, when they weren't doing well, I was the only person in the room putting my hand up and said, well, do we know why they're not doing well? We could assume they're all, doing the New York Times crossword puzzle and they don't care, and we can always punish them. But are there other barriers, right? And so I'm calling that out because it's a real world example. I think that I see that there is a role for medicine in health, but the two are not the same. And if we want to make an impact on integration of resources, and Walter, I'm totally celebrating your calling out the notion of integrator. It has global gravitas. We've just got to figure that out in the US. Does anybody want to talk about risk adjustment? Does anybody worry about stratification of performance measures? I'm sort of dropping some hints here.
And also a large topic probably for our February meeting as well.
Absolutely. Absolutely. So when we get those topics right, think about unplanned 30-day all-cause readmissions, right? It's a measure. Is it the right measure? Probably not, but until we get this meaningful stuff. So I want to encourage this group, be thinking about those social aspects. And so I think maybe this is a good point for us to pause. I've got a pretty extensive notes. Chelsea, do you want to do you want to share yours first and then we'll allow people to comment, or do you want me to share mine and have people comment? How do you want to do this?
I am comfortable with either. My notes are more stream of conscious transcription. I'm not sure if that will be super helpful. Yeah, I think we could do either. Or I also am just wondering, so the intent for the breakout group is to share 2 to 3 recommendations that should be refined or excluded. Any recommendations based on interoperability, which you didn't really touch on, but I think that is kind of an overlying thing that we know things will just kind of get better as interoperability changes. So I think if there would be curious if the group things that really stood out to them. I know things that I heard were about timeliness of data, accuracy of data, making sure a patient maintains ownership of their data, and able to give permission to share that, as well as kind of pushing that EHR data to other with patient permission, instead of necessarily going to an HIE to query it, because I know that does take time. And I used to work in the emergency room as a nurse, and you never had time to look in the EHR until like you've already seen the patient essentially. So I know that definitely resonated with me. And then I think there's a lot around data standardization and understanding all of that. And that's kind of the part where we know that's foundational to what we're working on. And we kind of put that in with the interoperability piece. And I think our next conversations will be really interesting as well. And I also really appreciated Alexis's point about despite it being for patients, not actually pulling out any patients for usability for those examples. So we'll certainly, I think that's a nice gap that we should probably highlight if the other group does not. And the focus on shared decision making, I think really resonated with me as well.
I've got my notes, but I'm not sure that, I'm happy to share, but does anybody on the group want to comment Chelsea's rapid synopsis? All right, so I'll keep,
if there's,
oh, go ahead.
yeah, oh, sorry, Rich. If there's anything that particularly resonated with you, and certainly if you think of things afterwards, we constantly want all of that that feedback. But if there's something that we talked about that you think is particularly important, that you think is important for the rest of the group to hear, I'm sure Rich and I would both really appreciate that as well.
Absolutely. Send it as an email if you want to embed it in the Word document that was here. So I'm going to sort of, I'm not going to repeat what Chelsea just said, but I'll tell you some of the other things. I particularly appreciated the idea of lack of interoperability at any level, even where we currently are, puts the patient family in a very burdened role, because even if the systems are internally integrated, it's on them to make sure the right information gets to the right place. And I think that's critically important. And then I absolutely embrace the idea of the care team as jointly defined by the patient family caregiver and the traditional care team, leveraging the idea of the integrator. There are both adult and child measures of perception of care integration. So the good news is we already have an outcome measure that we could be tracking. If we can make this work within this the scope of this project. Brent, I appreciate very much the idea of having access embedded in EHRs for evidence-based or evidence-informed care plans. And it isn't just the doc then being prescriptive with the patient and the family, but that in fact it is shared. Maybe the patient will come in and say, look, I've read this pathway on low back pain. Why do I need surgery again? And I purposely chose on that because there's an ocean of data and around that. And then Joe, I'm really grateful that you called out this idea of closing the loop. If we are literally getting food on people's tables, in fact, in some cases, we're getting people housing so they have a table. Well, how do we move beyond the checkbox of, yeah, I made a referral, I don't have to think about that. And that links, and I'll sort of close with, once again, leveraging this idea of the integrator. So imagine that bilaterally configured plan of care is tracked over time. And it'd be nice to know, rather than labeling a patient as non-compliant or non-adherent, for the integrator to say, you know, we've called 12 mental health providers. Nobody will see my child with autism or takes this insurance, et cetera. So it shouldn't move immediately into financial accountability and punishment. But in fact, especially when we're trying to connect the universes of the community resources with measurable health outcomes, especially equitably so, anything that doesn't meet the bar should actually trigger the process to be smart enough to say why. Why do we have all these unplanned readmissions? It's because we discharge people to the sidewalk. All right, and we are at 3:29. Is that good enough, Ms. Lynch?
That is perfect. We will let I forget what the main room is called, but we'll let them know that we are wrapped up. So soon we should probably see a one minute warning, and then they'll also pull us out as well. But really appreciate everyone's engagement. It was really nice to have the smaller group to make sure we could hear everyone. If you have any recommendations or thoughts about kind of the flow of this doing the breakout groups, please let us know that as well, because we are anticipating you doing this for the next 2 meetings as well, just so we can really dig in and make sure we hear everyone's perspective. So if you have any thoughts or feedback, definitely happy to have that as well.
So shall we
I
just
love the Gravity Project discussion. Katie, thank you for that. Go ahead, Alexis.
Oh, I was just going to ask if we should just click on the leave room and go back to the main room.
Oh, they're closing the rooms now. So I never even noticed that leave room button before, Alexis.
Okay. I didn't know if you wanted us here until they were ready or what.
Yeah, no, I think they'll close it, and then that'll give us time to stop recording and save all of our chats, which is great.
Please
And
feel
yes,
free
now-
to jump in the discussion in the bigger group.
Thanks, everyone.